the presentation. Over to you, Mr. Kampamba.
So thank you so much, and good afternoon, network, and good afternoon, panel of experts, those that have joined in. So today we are considering something that is very vital when it comes to the products that we introduce and are used by our recipients of care. That's the ARVs in the HIV program. So this just concerns the learning objectives that we have, just having an overview of pharmacovigilance, discussions concerning the key considerations in the pharmacovigilance, or PV as it will be abbreviated, and then also discussing the role of pharmacovigilance in the newly introduced ARVs in the country.
So at this point, we'll do our first poll question. We'll ask IT to launch the poll question. The question is concerning side effects and adverse drug reactions, which are abbreviated as ADRs. Choose the incorrect answer. So we have A, they are different, B, they are the same, C, the side effect is dose dependent, whereas an ADR requires doses normally used. They should all be assessed and reported. Again, encouraging the network to please participate in the poll. So again, concerning side effects and adverse drug reactions, choose the incorrect answer. So just be careful there. We are choosing the incorrect answer. These questions can be tricky. So just look at what is incorrect. So they are different, they are the same. C, side effect is dose dependent, whereas an ADR occurs at doses normally used. It should all be assessed and reported. Please encouraging the network to participate in the poll. You can still see a few more people that need to participate. We'll give it a few more seconds. We are under 50% participation. You are protected. Your names will not show as you participate. Just trying to get to the 50% mark. It's multiple choice, so please participate. Learning will take place after this, so please just feel free to participate. We're almost there, so a few more responses and we'll be just above the 50%. In the next 10 seconds, we'll be closing the poll. Okay. Okay, thank you, IT. I think for now we can, interesting results. I think we have the majority thinking they are the same. That is the incorrect answer. And again, Mr. Kampamba will speak to this. Okay, proceed with the slides.
Yeah, thank you so much. So the worry comes in when you have 100% going for the correct answer. Then you know that you are speaking to the choir, or you are preaching to the choir. So this is very good. And of course, let's go into more information about pharmacovigilance. So remember where we are coming from initially, where pharmacovigilance was only concerned with the product and nothing else. Oh, is this product safe? Is this product this and that? But moving forward, we saw the definition of pharmacovigilance being changed, and concern was raised to do with the person or the patient taking the commodity. So this is the science and indeed activities that relate to the detection. So you have to detect. After detecting, you make an assessment. And after making an assessment, that gives you an understanding. And therefore, you prevent the adverse effects or any other possible medicine-related problems. So we see that it also concerns the person who is taking the drug, and you try by all means to prevent these adverse effects and also manage, if at all there are things that can be managed while the patient is on those drugs. So like I said, in short, we'll be talking of PV, that's referring to pharmacovigilance. So it's a safety monitoring of medicines, and we know that where public health is concerned, it improves that, and the safety also in relation to the use of the various medicines that we have in the country. That's why you find once in a while you have recalls being announced by Zambia Medicines Regulatory Authority, or indeed in other countries as well. Just to eavesdrop on the global data. So, for example, in 2022, where America is concerned, they had reported a total of 1.2 million serious adverse events. Out of those, 175,000 deaths occurred. The reference, of course, is there. That was in the US. And of course, in Zambia, we know that we are just under 2,000 that were reported as of 2024, which showed, of course, an increase from where we are coming. So it means that people are beginning to appreciate the importance of pharmacovigilance. So now, concerning something that was asked in our poll question, I hope people are paying attention. So these definitions, I know at times are used interchangeably, but of course, if we are talking of just being critical and analytical, these are different. However, like I have said, in general use, they can be interchanged, but it does not harm you and me to know the difference that exists between them. So what is an adverse drug reaction, or ADR in short? This is a response to a medicine which is noxious and it is unintended, okay? Don't plan. And occurs at doses normally used. For example, you are taking the cotrimoxazole in this case, the normal dose, not that you have been overdosed or something like that, just a normal dose, and you end up having a rash. So things like that, that is what we call an adverse drug reaction. And we want those to be reported as much as possible, because some of these things may not have been picked during clinical trials. And then for the side effect, take note, side effect, this is unintended. However, it is predictable and is dose dependent, okay, to a medicine due to drug pharmacology. So this is known. It's very much predictable. Take, for example, you are taking an non-steroidal anti-inflammatory drugs, the brufens, the diclofenacs, and all. We know that you expect, you'll be expected to have some gastritis, so to speak. Or you are taking antibiotics and you end up having diarrhea or tummy upset. So those are the pharmacology behind that is well known and is dose dependent, like we have said. That of course we know that the more you take, the higher the dose you take, the more pronounced these become. Then we also have an adverse effect. So this is another negative or harmful outcome in a patient that seems to be associated with the treatment, including there being no effect at all. So those are the first three definitions that we're going to look. Now, moving on, we have an adverse event. Now, of course, some of these usually come up when we are doing clinical trials or some research where you actually learn to appreciate these definitions. So an adverse event is an adverse outcome that occurs while the patient or a person is taking the medicine, which may or may not be attributable to the drug that the patient is taking, and there is no causal relationship. For example, I am taking TLD, and as I go to town, I get swept away by floods. That's an adverse event that has happened while Davies is taking the TLD. It's not related. So such examples, or involved in an accident, or one breaks their leg while taking that drug, or things like that, or indeed it can be related, it may be related. And then we also have serious adverse event. This is an event that results into death or indeed life-threatening or hospitalization. So these are graded, of course, like we have seen. Sometimes they do lead to disability or incapacity, or indeed birth defects, or requires intervention to prevent the significant damage that has been experienced by the patient. And then severity, this describes just the intensity of a specific event. Like we have said, it may be mild, moderate, or indeed severe. And of course, the action at times, and depending on which one it is, you may have to withdraw completely or reduce the dose or manage the effects and things like that. Yep. Just giving us a scope of pharmacovigilance. So these are things that really concern us when we are dealing with medicines or drugs. And if we look at this, the 6 shapes here that we have adverse drug reactions or events. Pharmacovigilance is very key where that is concerned. Issues of medication errors. You and I know that if I give, there was an example that was given some time back when I was practicing where this client, a pediatrics client actually was paracetamol oral was written as, the syrup was written as IV, and the healthcare worker, the pharmacist or the pharmacy group gave the drug because they knew that it was paracetamol suspension. And then it went to the nurse, and the nurse gave, because the prescriber had written paracetamol suspension, route of administration, IV. And the child was given, and you definitely know what happened. The child died. So medication errors are very key when it comes to pharmacovigilance. Then issues of counterfeit medicines. Time and again, we do hear both within and without when medicines are recalled. And we know, of course, that ZAMRA in this case is highly mandated to be the police to just check these drugs, the counterfeit. And then issues of efficacy. So lack of efficacy is also very key. You and I know that if something does not have the strength, so to speak, that it is intended to have, we know that we are going to be brooding a monster, especially like for example, antibiotics, and in this case, ARVs as well. You want something that is efficacious. And then there's also the issue of abuse and misuse of medicines, and this is quite rampant. I remember some time back, we continued receiving reports that people were actually abusing the theory that we had. Because initially we had efavirenz, and we did away with the efavirenz, so they found a way of getting the TLE, crushing it, or to get the efavirenz effect in the TLE. So there is so much that goes on out there. And then, of course, we also have the interaction of medicines, so drug to drug. And in this day and age, we talk so much of the herbal remedies that people use. These may actually also have effects on the drugs that we take. They may potentiate, or they may indeed reduce the potency of these drugs. So why do adverse effects occur? Okay, like we have said, that slide that we have just looked at is very key. So the effects of any medical intervention cannot be predicted with absolute certainty. So just like Septrin, if someone is taking Septrin, we may not know that they will experience a rash. Otherwise, that's why we give them. If we knew, remember, we are not supposed to challenge. We are not supposed to give them the Septrin. So there is that uncertainty. That's why we give, and be observant once we have given. Like we have said, there is no medicine or medical intervention that will not have any negative and or undesirable effect. They say even water has side effects. So it's very important to know. But of course, the severity is important in this case, and whether something is tolerable or not. Again, medicines, by their nature, they are chemicals, okay, and therefore produce pharmacological effects. And these induce changes in our bodies physiologically. And that's why even when we talk of, let's say, pregnancy, we know that we are not supposed to give certain drugs because they will end up causing birth defects. You and I remember the story of the thalidomide issue between 1950 and 1960. That was being taken for morning sickness, where children were born without limbs, either upper or lower, or indeed both. This drug was being taken by women who were pregnant. And when they gave birth, they started noticing those. And when they were dug into the history of what drug these women had taken, it was pointing to the thalidomide. So there we see some physiological changes that definitely can arise as a result of these medicines, which are chemical in nature. And again, I'll keep on singing about the Septrin because that's a classical feature. So Mwaba and I may both take Septrin, and you find that I react to Septrin and Mwaba does not react because we are made differently. So we have individual variation. And this individual variation may be like within the country, or indeed it can be regional, so to speak. You find that maybe people like in an African setting don't really tolerate well this antihypertensive, whereas those that are in Asia do tolerate this. And even the issue of the excipients that are used in these drugs. We know that there are some, for example, antihypertensives brand specific. Some people do not tolerate those that are made in Asia. Others only tolerate those that are made in Europe or things like that. So it's because of that difference in our makeup as individuals. And like we said, information about these drugs may be very rare. Why? Remember, when these are being under development, there is a very small population that is used. So you cannot elicit all the effects that you want to see in that small population. That's why when the drug is rolled out to a larger population, you and I are key when it comes to post-market surveillance. That's where many things are brought out. Okay, so these effects that we are talking about, are they preventable or not? And of course, we're using adverse effect as a broader term in this case, okay? So some of these are definitely preventable, while others are inevitable and unavoidable. For example, if I'm taking, I'll use brand name Piriton. You and I know that Piriton will cause drowsiness, okay? So unless otherwise, we'll just tell you, take it at night, because we know that you are going to be asleep. If it's during the day, we'll give you something that is non-sedating. But there are some that actually can be prevented. Remember, we had talked about medication errors and things like that, okay? So some of them may include, during the manufacturing or preparation stage, you may find something was added and something is removed and a better excipient added. You would have done away with that which was causing some adverse effects. Again, during storage and transportation of medicines, we know there are drugs that, for example, do not expose to light during that storage. You expose to light, chemical reactions that take place, and therefore adverse effects will be magnified. And then prescription stage, like we talked about medication errors and things like that, and also dispensing stage. Okay, so here is Davies, who is seated at a pharmacy, and a prescription is given, and they look alike. Okay, we know that that is sometimes a big problem. Instead of giving Piriton, for example, because they are packaged in a similar way, I end up giving maybe an antihypertensive or things like that. Okay, so those can definitely be corrected. And then administration by a health worker, and then patient level. So in essence, we see actually that everyone has a key to play in this case. There are different stages from the manufacturer to the very person who is taking the drug. Here is Davies taking the drug. The prescriber had said 2 tablets 3 times a day, and the person who was dispensing actually said you take 2 tablets in the morning, 2 in the afternoon, 2 at night, and then Davies as a patient ends up taking 3 tablets twice a day. So flipping the coin like that, okay? All in all, we also try by all means to avoid using of substandard and falsified products, because they are a culprit as well. So the importance of pharmacovigilance, like we have said, is a very, very important aspect or science that permits us to detect, okay, less common, but sometimes very serious adverse drug reactions, the ARVs that we have talked about. I gave an example of thalidomide. And for your information, maybe unless otherwise, almost all of us that may be on this call may not have been there in the 1950s. But again, a good number of us were there when we had stabudine. We know that stabudine we did away with it. The effects are still being felt of this drug that we had. So pharmacovigilance is very key. You report, I report, he reports, another person reports. At the end of the day, these reports are aggregated, and we end up now having a database, and then the drug is done away with if the effects are adverse. Okay, so like we have said, information collected during the pre-marketing phase of drug development is not complete. You are dealing with a small population, and usually during clinical trials, you're dealing with many healthy individuals. Okay, now you are in a wider population, using this drug in a wider population, and therefore, and these may have disease and different genetic makeup, and you end up now having definitely these effects elicited. So post-market surveillance is very, very key in this case.
We come to our second poll question. IT, you can help us launch the question. So why pharmacovigilance in Zambia? Please choose all that apply. So we have detection of substandard and falsified medicines, detection of very rare events not identified in clinical trials, and C, Zambia has the same patterns in ADR occurrence as other countries. D, improvement of information in labeling. Then E, or apply, except C. We encourage everyone to please attempt the question. The question is why pharmacovigilance in Zambia? Again, for this question, choose all that apply. A, detection of substandard and falsified medicines. B, detection of very rare events not identified in clinical trials. C, Zambia has the same patterns in ADR occurrence as other countries. D, improvement of information in labeling. Then E, or apply except C. Again, please take note that except sometimes gets to confuse people. So please attempt. We have quite a number of people that are attempting, which is excellent. We encourage everybody to please continue attempting. I think we are targeting at least to have 50% of the network attempting. Again, these are multiple choice questions. So please attempt. That's the only way we get to improve. So test your knowledge at this stage. We are almost at 50%. Please, network, continue attempting. Why pharmacovigilance in Zambia? What do you think? Is it A, detection of substandard falsified medicine? Is it B, detection of very rare events not identified in clinical trials? Well, by few that are saying it's C, Zambia has same pattern in ADR occurrences as other countries. We have D, improvement of information and labeling, and E, or except C. So almost all the responses there, the options have a response from the network. I think at this stage, we are past the 50% mark. Thank you so much, IT. Mr. Kampamba, you may continue to take us through the slides.
So again, it's very interesting. A normal curve has been followed. Of course, we have people going for different answers in this case. And there was a little leakage before we came to this slide. And of course, the majority have taken the day. Let's talk about some of the key principles and processes that are involved where pharmacovigilance is concerned. Like we said, you have to detect, assess, and that assessment to an understanding.
Please, network, you may mute yourself. Mr. Mansa Samilani, please mute your mic.
Okay, so like we said, you have to detect, assess, understand, and then prevent. Okay, once you understand that, oh, this is what causes this problem that you have, I mean, it will only be wise for me to therefore put prevention measures in place. And this is through systematic monitoring of medicines, the post-market surveillance that we've talked about, with a focus, of course, of identifying new safety concerns. Okay, we know that there are certain, like I gave an example, drug-drug interactions or drug-herbal interactions. We know, for example, if this herbal product potentiates this particular drug, and therefore with the potentiation of this particular drug, more side effects will be seen in this client. We know that someone will have to be told, please avoid this combination as much as possible. Then we also have cases where the effect of the drug is reduced markedly. Again, That's why we don't take these drugs with other drugs or food or indeed such things. Again, we also do have continuous analysis. This is not just a once-off thing. Our eyes are ever open. And thankfully, we have ZAMRA, which is, again, mandated to oversee pharmacovigilance in the country, mandated by the government. And they have that watchful eye. That's why time and again, you will see that there is this drug that has been recorded. And at times, it's worrying when you hear the general populace actually condemning ZAMRA. Why do we have so many recalls, this and that? Remember, some of these drugs, at a point that they enter in, they are perfectly okay, and then now rolled out to a larger population, like we have talked about. And again, Zambians may react totally different in the way that maybe South Africans may react, okay? Or indeed, maybe during storage and something like that comes up. So all those things are elicited when ZAMRA is actually making their reports. So there's also continuous analysis of data. We just evaluate the causality. What is it that really caused? Is it something to do with the manufacturer stage, or is it during distribution, or is it during storage? Or indeed, was it just a medical error, so to speak, where maybe the prescriber or the pharmacy, when giving out this drug, or indeed it was a patient? So all those things are analyzed, and that is definitely continuous, which is quite good. So at the end of the day, when ZAMRA, for example, is so vigilant, you end up seeing much of this being gotten rid of, and you have this recall. We'll see a picture of the latest recall that we saw a few days ago, okay? And once the causality or the analysis is done, we know that there is communication of findings to the general public and the authorities, just to make sure that patients are safe. And that may result in drug recall, like I've been explaining. And like we have said, involves activities like signal detection, risk management, regulatory oversight, and public health protection. And of course, like as we are talking right now, our ZAMRA colleagues are actually doing trainings in pharmacovigilance, just to enlighten the health workers and things like that when it comes to these things. Okay, we continue, like we have said, signal detection, okay? Patient safety is very key, okay? So potential safety concerns by analyzing data patterns and trends. So if we see something is mostly occurring, then we know that there must be something the problematic here. Causality assessment, evaluating the likelihood that a reported adverse event is related to the medication. So like we have said, of course, imagine you keep on having children, for example, swallowing the iron tablets, which their mothers are taking who are expecting every now and then. So you actually see that that will lead to a conclusion that probably the seal or the closing of this bottle of the ferrous sulfate is not actually good, is defective and things like that. And therefore that drug will be recalled. Okay, so there are several things that arise from that. And then risk management, developing strategies that will minimize potential harm associated with this medication, several things in place. What are some of the benefits? I think we have been singing about this. It will, I'm sure, be monotonous for me to really go through this. But one key thing, prevention of medicine tragedies. You don't want to fall back on the effects that we saw and we continue seeing with stabudine, for example, and also thalidomide. So we try by all means to not go back to those. And then pregnancy as well is very key. That's why even when we introduce newer drugs, remember when we introduce new drugs, we are not saying this drug is contraindicated because it has got adverse outcomes in pregnancy. No, we are cautious, because even when clinical trials are being done, they are not done in pregnant women, okay? So as now people start using it, you find there are cases where one falls pregnant while they are taking this drug, and then that baby is followed up with that mother, and everything ends up well. Then we know, oh, then definitely this drug is quite safe. So things like that. So pregnancy is very key as well. So when we have said don't use this in pregnancy, it's all mainly because of insufficient evidence available at a time. But once the information is available, we give a go-ahead. The case of cabotegravir, long-acting that we have in Zambia. Issues of counterfeits, we've talked about that. Then safety in children, you know, children are very special. We are very particular about them. And that's one of the reasons, of course, that we don't have so many formulations for children, because they're also not part of the population that is used during clinical trials. So now let's talk about active pharmacovigilance. So I should have mentioned that what we were earlier talking about was mainly just passive or routine surveillance of pharmacovigilance, where if I am taking, for example, TLD, it's a bad example, I'm taking paracetamol, okay, or indeed any other drug that you can think of, cotrimoxazole. If there's nothing that Davies has experienced, you won't document anything where pharmacovigilance is concerned, those forms that are in our facilities. Now, for active pharmacovigilance, okay, which of course in this case would be quick to say, with the introduction of the newer molecules that the country has seen from about 2017, 2018, and I'm talking about DTG-based regimens, the TAFET, the TOD, okay, and even the DTG itself, the PDTG that is, and then the DTG-50 when one would have been on AZT, 3TC, DTG. We set up sentinel sites across the country, and these were in Lusaka, and in Lusaka we had, for example, Chawama, Kanyama, UTH, both adult and children, and then Copperbelt we had KTH and then TH, and then Central Province we had Kapiri Urban, and we also had Kabwe Central, and in Southern Province we had Livingstone UTH now, and Champande. So these were initially doing the active pharmacovigilance where DTG-based regimens were concerned, and pregnancy as well on ART. Now, of course, with the introduction of Kabele, more provinces were added to that. Again, I'm sure we know the sites that are providing Kabele. We still have in Southern Province with an addition of Maramba and Mahatma, and then Kabwe as well, maintaining those two, Lusaka. Central Province also has Mwanjuni, Copperbelt has about 5 or so. So there has been an expansion to other provinces as well, like Muchinga Province. So these the introduction of newer molecules as WHO would recommend, we're supposed to set up a robust system to actively detect or report side effects. And in this case, when Davies comes to the facility, if the drug goes well, it doesn't report anything, I'm still supposed to document no side effect or no ADR reported. So that at the end of the day, we will have the total number of patients that are on this drug and how many have reported something adverse. So you have the denominator. Whereas for just the routine pharmacovigilance, you have no denominator, so to speak, because you don't document those that are not reporting anything. And like we have said, the APV is very key for newly introduced ARVs, including Kabele. So we continue with the principles. This APV enables us to specifically monitor adverse drug reactions, which would be associated with these newer drugs, as well as drug-drug interactions. I keep on talking about the herbal remedies, which the country has seen the demand rise so much. Everyone talks about herbal remedies, and we forget at times that those may interact with the normal drugs that people are taking, and then the issues of comorbidities as well. Okay, then we also address such challenges as underreporting, which may be caused by overburdened healthcare systems. And then, like we said earlier on, we report both the presence and absence of adverse drug reactions. I think we've talked about this. This is just now itemizing those drugs that we are talking about, that Zambia being usually an early adopter, and for your information, WHO is very, very interested in our data on how Zambia has been managing its HIV program. So it's like Zambia leads and others follow. We were one of the early ones to introduce TAF, and now there is a move actually to have more weight placed on TAF-based regimens compared to the TDF-based regimens. So there we are. So we report, we get those credits as well. Like we said, WHO is very happy and recommends robust and strengthened monitoring when you're introducing these drugs. So this is just giving us the differences between the passive or routine and the active pharmacovigilance. I think we have been seeing some of these. Some are similar. Then there are also differences. Of course, remember, if you are actively doing something, you need to pump in a little bit more money. Okay, so it may be costly, but at the end of the day, you do a great job because you have credible data that will inform you whether to continue using this drug or not. And like we said initially, like for passive pharmacovigilance, it's everywhere and anywhere. As long as something is reported, you have to capture. That's why we have those books. But for the active pharmacovigilance, you may need to start with some facilities, then roll out to other facilities as well, like we have in the case of Kambele and the DTG-based regimens that we talked about, just like it is for PALD, which is a pediatric formulation. And there are other similarities and differences that are listed. Let's talk about reporting.
Thanks. So we have our third poll question. Who should report? Choose all that apply. IT may launch our poll. So who should report? This is regarding pharmacovigilance. So option A, healthcare professionals in public or private facilities, including NGOs. B, patients and caregivers. C, non-health professionals. D, non-healthcare professionals. And that's a repetition, C and D. Then E, all of the above. What do you think? Who should report on pharmacovigilance? Choose all that apply. So we have those 5 options. Of course, C and D are the same. So what do you think? I think we have people polling. So far, the majority think it's E, followed closely by those that think it's healthcare professionals in public or private facilities. This should include NGOs. Of a few that are saying it's patients and caregivers, and we also have some that think it's non-healthcare professionals. Quite interesting point, especially between A and E, where we have the majority thinking it's either all of the above or it's only healthcare workers.
Very interesting. Again, votes are being split, which is good. Well, not that we want people to get it wrong, but it simply tells us that people are in the right classroom.
Thank you. We have very good participation. Please keep it up. We have a few more seconds just to allow a few more people to cast their thinking. Just 5 more seconds before we close the poll. We can get in 1 or 2 people to submit. And just for our experts, if there are any questions in the chat that you can attend to, please network, feel free to use the chat. We have got quite a number of experts on the call that will be responding to some of the questions. I think we can now close the poll. Thank you so much, IT, Mr. Kampamba. we have the majority thinking it's E. You can please proceed with the slides.
Oh, yes. So this is one of the times that the majority win. So yes, so the majority have carried the day. I remember one of the points that should have been there actually is the fourth bullet, manufacturers and marketing authorization holders. Those are supposed to be part of the people that are supposed to report. So it cuts across. It does not exclude anyone. I know there are cases where we have come across where some healthcare workers will say, no, we thought this pharmacovigilance or active pharmacovigilance is only for pharmacists, or we thought it was only for nurses, or we thought, no, it's only for doctors. It's everyone, including the patient and their caregivers. Okay, so I think this is what this slide is talking about. At the end of the day, ensure that we report, our reports are completed, because all the information that is key on those forms is needed. Now we'll see the kind of information. Here we are. So like we said, what should be reported on? All medicines related problems such as side effects, ARVs, ARVs, that's medication errors should equally be reported. Okay, product quality problems, those counterfeits, substandard. Again, we have had cases where you find maybe normal saline, you hang it up there, then it keeps on dropping because the hook is not fixed nicely, or indeed while you hook it up there, it starts discoloring. So things like that. And then the one that is greenish looking, that is the shower item made by Shalina. I think it is in the public domain. That was that on the 2nd or the end of last week, just this March actually. There was a recall that was sent out by ZAMRA concerning this product. And manufacturer and suppliers have since withdrawn. So again, if you have this product, there's a batch number. Look out in the media, you will see the batch number that has been given out concerning the quality of this commodity. So it has been recorded. So there we are. Our reporting does work. All in all, maybe just go back. I just want to re-emphasize on that. All in all, our reporting ensures that safe, quality and efficacious medicines are available on the market for all of us. Okay? The thing with medicines, today I may not be taking any medicine. Tomorrow I'll be sick and I may be taking some of these products. And I may be a victim if I'm not vigilant when it comes to reporting these errors. So please, my report indeed counts. So this is just running us through some of the data elements that are in those forms that we report and are needed and need to be completely filled in. Where side effects are concerned, again, it's clearly indicated. We have to identify the patient or the victim in this case and what reaction, including the diagnosis there. What medicine was this person taking? And of course, we have to dig into the history. Otherwise, if I say I have had this rash from last week Friday, and yet I started taking this drug yesterday on Sunday, right? Yesterday on Sunday. So we know that there may not be a causality in that case. So date is very important. And then the reporter also. I know there are times that we feel like, oh, if I put my name there, then I'll be followed up. No. You are helping us, my dear friend. So we need, in case of anything, we need to get in touch with you, or indeed we need to get in touch with an institution. But that information is very key where the reporter is concerned, including the phone number, so that we may be reached out. It's not punitive in this case, not punitive at all. And then concerning the quality of the product, again, description of the suspected product and what problem we have experienced. So batch number is very key in this case. Who is the manufacturer? Who is the supplier? So all those details. Again, some people are afraid, no, I don't want to report that it is DK Pharmaceuticals as the main supplier of this drug because they may be closed up. Well, if they don't get closed up because they have been supplying substandard products, they will affect me or my neighbor or my own relative. So it's key to report. So these are some of the reporting tools. I am sure we are very familiar with these. Again, the information that we have just been reporting about where side effects are concerned is extracted from these forms. There are those ZAMRA books that are distributed in our facilities. And please remember, everyone is supposed to report. So it's not like this book is only supposed to be in the pharmacy. So even the doctor room can be there. Where the nurse is, it can be there. But of course, we are not saying that the patient can be given that book so that they go with it, because the information that's there may not pertain to them when it comes to filling in. But they can still report. There are various tools that are used. Like we have said, the Med Safety app, this is a free smartphone app. So as long as I have a smartphone, I can access this. And the good thing is, it's a simple tool. It lets me report adverse effects, okay, and also keep track of the previously reported information and receive official news and alerts. That's a goodness with this. And with this, of course, I should have also mentioned that when it comes to adverse drug reactions pattern, they may differ from country to country. Remember, our genetic makeup is different. You and I know that even when it comes to TAFET, in South African population on Botswana, there were a lot that were reported to a lot of weight gain, so to speak. But in Zambia, it was a different thing. And so it is for other drugs. So that question that came, it was a wrong one. The patterns are different, of course, depending on which country. And therefore, you also expect that even the practice may be different, and therefore the rate at which people report may totally be different. Okay, this is just a web-based e-reporting form. Again, the website is there. The QR code can be scanned there, and the information that is needed definitely will pop up as you go into this. And then we also do have things that were developed for active pharmacovigilance. I know for those facilities, sentinel sites that we mentioned, you may be familiar with this. We have RedCap that also has been harboring our active pharmacovigilance reports. And then some good news. I know some facilities may have been tedious to print and to fill in manually all these and then store them away and things like that. So there's a module that is being developed and nearing completion. And by now we should have actually finished, but it should be out very soon. Just like we have this interaction with a smart care that we use in our interaction with clients. So for ARVs, we'll have this module, and once it is active, okay, it will be able to generate a case form and participate and enrolling of all clients on those ARVs actively. So there are several questions that will be coming out there that would have been replicated from the RedCap that we have and the form that we are going to see on the next page that we have been using. So there will be a pop-up, of course, for the APV module for all recipients of care. And this is the form that we have been using to print manually, and then people have been filling in. So the information was extracted from this and then placed on the smart care module that is under development. Okay, again, like we said, we have ZAMRA, which is legally mandated to do all the pharmacovigilance work. And in this case, those reports that we have been talking about, please make sure that they are sent to the National Pharmacovigilance Unit at zamra.co.zm/pharmacy@zamra, or rather, pharmacy@zamra.co.zm, or indeed npvu@zamra.co.zm. And there's a WhatsApp line there. You can actually WhatsApp. I know most of us are usually on WhatsApp, so there it is, life made easy. But of course, we also do have those tools that I talked about, the RedCap, and then that form, and then eventually we'll have the smart care module that is going to be at our disposal in our facilities. Yeah.
Okay, thank you so much, Mr. Kampamba. At this stage, I think we can have our pause. IT, please, let's report. I think now we have all the information. Let's see how the network is going to do. There are some comments in the chat and some questions. So we'll have just 30 seconds to go through the poll. The question is concerning side effects and adverse drug reactions. Choose the incorrect answer. So we have about 30 seconds for this. Network, you're encouraged all to poll, please. We have gone through all these sections, so we have about 5 more seconds. Okay, thank you, IT. We'll ask Mr. Kampamba to really speak to the answers. The majority are saying B. They are all the same. So maybe you can speak to that one.
Yeah, so again, I guess the others that have chosen the either A, C, or D probably may have joined us late, or maybe they were dozing. Yeah, but otherwise the answer is C. They are the same. So that's a wrong one. They are not the same. Okay, so they are different is correct in this case. Sorry for confusing you. Then for C, we know that there's actually a difference in there. You see that a side effect is dose dependent, whereas an adverse drug reaction occurs at doses normally used. Take, for example, septrin. When you give septrin, you don't have to give an overdose for someone to experience rash. Okay, but of course we know, like for for diclofenac or brufen, we know that the more you increase the dose, the more side effects this person will be experiencing. So yes, the answer is B. They are the same.
Thank you so much. So the trick there was in incorrect. Which ones choose the incorrect answer? We can have the second poll question. IT, you can launch the second poll question. So the second poll question, why pharmacovigilance in Zambia? Choose all that apply. Again, A, detection of substandard and falsified medicines. B, detection of very rare events not identified in clinical trials. C, Zambia has the same patterns in ADR occurrence as other countries. D, improvement of information in labeling. And E, all apply except C. We have some that have already polled. Network, we have about 10 seconds to go before we close the poll. So again, quite interesting. The majority are saying E. We have a few that are saying A, B, C, and D. So maybe again, we'll ask you to speak to those. Thank you, IT.
So again, very, very interesting. I know there are some people that may be voting so that they just balance the curve. At the end of the day, you're supposed to have a normal curve. So E is the correct answer in this case. Or apply except C. So remember, we use pharmacovigilance to detect substandard or falsified medicines. We also use it to detect those that are very rare events that may not have been identified during clinical trials. Otherwise, if they were identified, like the thalidomide story, if they were identified during clinical trials, there was no way that that drug would have been introduced to be used in the general public. Then C, Zambia has the same patterns in ADR occurrence as other countries. Like we have said, I think that's about 2 or 3 minutes ago, we were singing about this. The wrong word there is same, so it's not the same. And then D is correct, improvement of information in labeling. Like I said, we have those look-alike bottles that confuse people. You end up giving an exam, a mistake. So you end up making a mistake when giving those drugs. Remember, even in theater, we have seen serious effects happen there because someone mistook this drug for another drug. So with those reports, there is an improved labeling that will arise or apply except C, therefore.
Thank you so much, Mr. Kampamba. We can have the third and last poll question. Who should report? So choose all that apply. Again, the question is who should report. You can choose all that apply. It's a multiple answer question. A, healthcare professionals in public or private facilities, including NGOs. B, patients and caregivers. C, non-healthcare professionals. D, again, it's a repetition of C. E, all of the above. Again, the majority are saying E is the correct answer. We have a few that are still think A is the answer. Others think it's B. And we have, I think, about one each, two people that think it's non-healthcare professionals. So again, we'll give it 5 seconds and then we can get a comment from Mr. Kampamba on that.
Again, sorry for those, I can see in the comment that some people can't see the poll. We've gone back to the poll questions that we had, and right now we are just asking who is it that should report when it comes to pharmacovigilance. Like we said, everyone from the manufacturer to the healthcare worker to the client and even the caregiver. So, and it includes non-health care professionals, including people out there. So everyone is mandated to report because it concerns you and me. And therefore, like we said, our report counts. I hope we shall report to ensure safe, efficacious, and quality medicines are out there to be used on us and our clients. Thank you.
Thank you so much, Mr. Kampamba. Indeed, wonderful presentation. We have experts that have joined us in the room. I have Madam Mumbi. I'll ask her if she has any additions to the presentation that has been made by Mr. Kampamba. On the call, I also have Mrs. Melody Mbewe, Jean Mukumbuta that are joining us. I'll also ask just for a few comments from the experts, anything that they have to add to the presentation that Mr. Kampamba has made. We'll start with Madam Mumbi. Any additions to this presentation? We also have from ZAMRA, who has joined us, who also ask a comment from there. Over to you.
Can I go? Thank you so much. Thank you so much, Chair. Yes, I think maybe just to emphasize. Sorry about that.
Some IT issues, Madam Mumbi, can now speak.
Yes, I just wanted to emphasize on the reporting aspect. I think there was something that was asked in terms of whether these reports are actually being looked on at ZAMRA. So ZAMRA does actually send an acknowledgement when they receive these reports. So they are actively recording them and compiling them. And once in a while, they do produce a report where they give information in terms of those provinces, that how are we reporting per province, and all that information, and which are the most common adverse drug reactions that are being reported as a country. But however, there is a need for more regular updates. So we are going to be working with ZAMRA to ensure that at least we have these regular briefings and dissemination of this information. And also in terms of having focal point persons, I think it's something that is being encouraged at facility level to ensure that we have focal point persons who can spearhead pharmacovigilance, but also to use the medicines and the therapeutics committee meetings to ensure that this activity is ongoing. And of course, sharing of this information with all healthcare workers. Remember, the emphasis is everybody should report. So it's not a pharmacy activity alone, but all the healthcare workers. And have you heard also patients can report just using that app, which was shared by Mr. Kampamba. So let's make sure that we encourage medicine safety, medicine monitoring as we are prescribing, as we are dispensing, and as we are utilizing these commodities. Thank you, Chair.
Thank you so much, Madam Mumbi. I will go to Mrs. Melody Mbewe from UTH Adult Center of Excellence. Mrs. Mbewe, any additions to the presentation? And if we still have Mrs. Mbewe.
further additions. Thank you.
Okay, we can go to Mr. Mluwachilambe from ZAMRA. Any additions as well as just any comments on the reporting, the reports that you are receiving as ZAMRA, and also maybe just any general comments that you may have, as well as feedback to the facilities. I think that's one of the issues that usually comes up when it comes to pharmacovigilance. So I'd love you to also speak to some of those issues. Over to you, Mr. Mluwa. Yeah, if you are speaking, you're on mute. IT, I don't know if Mr. Mluwa is able to unmute himself. Okay. Just checking through. I don't know if you're speaking, we can't hear you.
Okay, so thank you so much, Mr. Kampamba, for that question.
Sorry, are you able to just move closer to your mic? We can hardly hear you. Mr. Shilambe, we can hardly hear you. I don't know if you're able to move closer to the mic.
Can you hear me now?
Yeah, it's better now.
Can you
please go ahead?
Hear me now? Are you able to get me?
Yes, please go ahead.
Okay. Thank you so much. Thank you, Mr. Kampamba. Wonderful presentation. So for me, just want to continue being in one of the developing countries. The country with low economy, we are targeted for important, but we keep an eye.
I don't know if it's just us. Are you able maybe to just
still can't get you?
You keep breaking, so we can hardly hear you. I don't know if you're able to just post your contribution in the chat. Okay, thank you. We can post in the chat. We'll ask Jean to also maybe just a comment before we go to the network.
Thank you so. Yes,
yeah,
thank you so much. Thank you so much. It was a great presentation. So just to add on, I'll just encourage the network to intensify on pharmacovigilance in our various facilities. So really pharmacovigilance, it's a professional responsibility for all the healthcare workers. It's not just for pharmacy personnel. So even as regards focal point persons for various facilities, anyone can be the focal point person. So I just want to encourage the network to be vigilant, especially on pharmacovigilance in pediatrics. It's something which is not usually reported. As Livingstone UTH, we've seen quite a number of ADRs among the children who are being admitted at our pediatrics ward. So let's intensify pharmacovigilance in the pediatrics population. And also currently we are having lookalike medication. You find the 3 different types of drugs coming in the same package and same color, so which is actually causing some medication errors. So we need to intensify pharmacovigilance in that area. Different brands also of commodities. I'll give an example of the TLD. We've been receiving different brands of TLD, and if you talk to your patients, you ask about the side effects, ADRs that they are experiencing, you find that some clients, they'll actually will not respond to a different type of TLD. They'll respond well to another type of TLD. I think someone mentioned in the chat to say, is there, people are reporting on side effects of TPT medication, but it's like nothing is being done. So if we don't report as facilities, ZAMRA will not be able to know that actually this brand or this drug is actually causing a lot of harm to the population. So I would encourage each and every one of us to make sure we report. Just by sending that one report, you can actually save a lot of lives. Thank you, and over, Chair.
So thank you so much, Madam Jean. Network, we are now opening up for any questions and comments. You can raise your hand, come off mute and make your contribution, either question or any comments. Since there were quite a number of comments in the chat, and thanks to the experts for attending to some of those questions. In case your question has not been attended to, you can raise your hand, and then we'll be able to address your question. Even comments are welcome, so please feel free to also provide any comments. Any comments from the network, or any questions, anything that needs to be clarified? This is your opportunity now. You can use the raise hand feature. I can't see any comments. I think just reading through some of the questions and comments that were coming through in the chat. I think this was from PK Health Facilities. You have a focal point person in pharmacy department to just encourage other health professionals to use the reporting tools and follow up as well. Madam Mumbi did indicate that they have identified focal point persons to spearhead the safety monitoring and surveillance of medicines and medical supplies. Very important. Each facility should have a PV subcommittee. This is Mbewe, and this should be under the Medicines Therapeutics Committee. And PK again, where are we so far in general in regards to pharmacovigilance? I feel like once patient reports some side effects, it's not actively taken up or investigated. For example, TB prophylaxis. Some patients reported rash, muscle aches, and other side effects, but not sure if these were actively reported. So Mbewe there commented that of late there have been some improvements in the reporting system, though more needs to be done. When the patient complains, reports, please proceed to fill in the PBA report. I think it would have also been interesting to hear from Mr. Mluwa if there are any deliberate efforts. I think he's posted something in the chat. We're encouraging the use of digital platforms for quick transmission of ADR reports. So you can find these on the ZAMRA website, which is www.zamra.co.zm. I don't know if you can also maybe speak to the issue of feedback, Mr. Mluwa. How are we doing so far? Have we seen improvement in terms of feedback to the facilities as they report? In the meantime, we can get a question or comment from Jackson Mwewa, who said action. Please unmute and proceed with your question or comment.
Okay, thank you very much. The presentation was actually very insightful. However, I wanted to find out most of the time we are recalling, for example, benzyl penicillin. I wanted to find out what intervention is being put in place to ensure that each and every client or a patient who actually had that drug in question being administered to them, they are called and what other services do we provide to such patients? I submit, Chair.
Thank you so much, Mr. Kampamba. Would you want to do a first attempt, and then the experts can add, if any?
Thank you so much. Of course, I know my colleague Muruwa is on the call. I would give an example of how they handle some of these recalls. But from our perspective, so when a drug is recalled, for example, I'll talk about, let's say paracetamol. This particular paracetamol has been recalled. So there are those clients that may have been taking the paracetamol and may have experienced some adverse outcomes. I know there are cases where manufacturers or indeed suppliers have been mandated to actually compensate. So it's a case of where people have to come forward. And that is why the recalling is made public, so that should there be, and I become the police as well. if I go to this particular shop, I find this batch is still being sold or it is sold to me, I would definitely encourage those people to pull it down from the shelf or indeed report to ZAMRA. And again, ZAMRA is very welcome to actually receive those reports. So reports are made public so that anyone who may have experienced something comes forward, and interventions definitely are made. Where, let's say, if someone has experienced some serious rash with a particular brand of drug and it's seen that that's very rare and things like that, they'll go to the nearest hospital and they'll be given the management that they need to be given to just treat those adverse outcomes. It's quite unfortunate, of course, at times if it has led to permanent disability. But like we said, the manufacturers in this case and the suppliers would be held accountable to make sure that compensation is made in that case. Otherwise, the reports are public and it is up to you and me to heed those reports and come forward if I'm experiencing anything. Thank you.
Thank you so much, Mr. Kampamba. And I think this is where also the ministry is encouraging that active pharmacovigilance, and that you had mentioned we are not just looking at adverse events or adverse effects of these drugs, but also quality issues. So that means that once there's this report, we should take it upon ourselves. And as was mentioned, everyone is involved, everybody who is in this cycle. Okay, we'll move to Machi. Please go ahead and unmute, make your contribution.
Well, thank you so much. Good afternoon, everyone. So just a question. I think most of what has been discussed today with regards to pharmacovigilance interventions that are being implemented in health facilities where patients come through, and either in the active pharmacovigilance or the passive pharmacovigilance that happens within the facilities. But are there any interventions that are being used to facilitate easy reporting from the general community? I think from my observation, most of what I have noticed is that ADRs are usually just identified when a patient walks to the facility. But we do understand that, of course, even when we talk about drugs, the other community, and is ZAMRA looking at any ways of increasing participation from the community with regards to reporting on these adverse drug reactions away from the facilities? Over.
Thank you so much. That's an amazing question, and Mr. Shilambe is already off mute, so please go ahead and respond. That's a very good question.
Okay, thank you so much. I hope this time I'll be heard.
Yes. Go ahead.
Okay, thank you, Mr. Mando, for that question. Yeah, actually, we are encouraging everyone to take part in the reporting of ADRs, not just healthcare workers, but everyone, including the general public. On the ZAMRA part, we have made our reporting tools public. They're accessible on our website. And the reporting form for ADRs, as well as for adverse events following immunization, are quite user-friendly for the non-professionals. So everyone is welcome to report. And those tools can be used even by people who don't have medical knowledge. The language used in there is quite simplified. And then I wanted to touch a bit on the part of the feedback. So I think in the past year, 2024, we did manage to at least acknowledge all the reports, almost all the reports that we received. And I think in some of the conversation we've had with especially the focal point persons, this feedback has really helped us. And one thing I could speak of, I think Mr. Mando would attest to that. There were a number of reports that they thought they had shared, but there was an error in the email address and they didn't reach out. So when we did the compilations in December, we're trying to balance things. I reached out to Mr. Mando and Waheb, and they were able to see those issues. So it is quite important that we provide this feedback in terms of acknowledgement of receipt. And we have seen how that can improve the reporting. And then on the issue of recalls, Mr. Kampamba has responded to that one very well. Treatment of patients is provided for free of charge by the Ministry of Health. So if anyone has been harmed by the harmful effects of the products or drugs that have been recalled, or they had some quality issues, they can go to the nearest facility or any hospital in Zambia, and they'll be given that treatment free of charge. But it's important to note that whenever there is a recall, as pharmacovigilance people, we should be happy because we know that there's a quality management system in place and it is working. We are able to detect bad products and we are able to honestly to be honest about these issues and remove them from circulation so that we can prevent further harm from happening. We protect the patients because that's our target in pharmacovigilance. So we shouldn't look at recalls as something that is bad to the system. It has its own disadvantages, but as pharmacovigilance people, this should be a plus because it shows that the system is able to detect these problems. Imagine we are not able to detect any of these, it will be chaos. So we should be happy that at least we're able to detect the problems and we are honest enough to come out in the public and say, we are recording these products, please don't use, rather than just hiding. Maybe we are scared that people will start suing people. That shouldn't be our line of thought. Thank you so much.
Thank you so much, Mr. Mlowa, for those responses. And as we take the next question from Malumbo, also just wanted to add a follow-up question to what Mando had asked. Maybe it's an issue of also what ZAMRA is doing to sensitize the general public, knowing their responsibility. I think for healthcare workers, we have such platforms like the ECHO session, the discussion that we're having today. So at least they're enlightened about how they can report adverse events, how they can be on the lookout. Maybe you can also speak on what some of the initiatives that ZAMRA may be doing to just sensitize the general public on that. But we will allow Malumbo to also ask a question, then you can respond to the two questions.
Thank you so much. It's been a very insightful presentation, and it's been quite interesting to listen to some of this information. So my question was relating to the people that are reporting these cases at facility, and it goes to ZAMRA. I do understand that in most cases, there are a lot of reports coming from health facilities, and some of those reports actually have management to where the people that are recording are actually managing some of these patients. I just wanted to find out if ZAMRA does take some time to individually reach out to these people, especially the ones that are managing, just to find out the outcome of the patient. Has the patient recovered? Has the patient still recovering? Or just to reach out to them to find out what exactly might have prompted the management they did. I feel like it could be a way of encouraging people who report these cases and just receiving an email and saying reports are in receipt over my submission.
Thank you. Another great submission from there. There's also another submission, Mr. Muluwa, before you come in terms of dissemination of results. How is that being done? As ZAMRA, at the end of the year, do you disseminate these reports? For example, this year, these are the number of reports received, and categorizing the various adverse effects that were reported. If so, what platforms are you using to disseminate? I feel that's another way that healthcare workers can be encouraged if they have access to some of those reports. So, Mr. Mluwa, over to you. Maybe you can respond to the three questions.
Okay, thank you so much. I'll start with the sensitization for the public. So we have been on social media, we are on radio, we are on TV. I think almost every week there is somebody from ZAMRA who goes to either a radio station or TV, mostly ZNBC. So we have been talking about side effects, among other ZAMRA-related issues. So those are the platforms that we're using to sensitize the community. And I know we still need to do more in terms of sensitization, and the partners that can manage, they can still come on board and help us with the sensitizations of the community. So one thing we are looking at with across, want to put a message on the immunization card so that the mothers, when they experience those side effects after vaccination, they should know where to report and how to go about it. So we're trying to put that message, just a sticker on that card. So there's a partner that will help us with that one. With regards to the outcome of the AGL, following up on each report with the people who reported, and not just an acknowledgement of receipt. So that's some very good practice that has been suggested by Malambo. However, we sometimes receive quite a good number of reports almost at the same time, and it can be overwhelming just to make those phone calls and follow-ups. Then sometimes also the people who report, they're not just there in the facility waiting for you to call them. So we make sure that even when we want to reach out, it is some information that will help with the assessment of the report. So it is good that to reach out, people may feel encouraged, but at the same time, people might be disturbed over the information that may not be really necessary for the assessment. And so we go case by case. Certain reports, it's a must that we follow up and get that information. For some reports, especially the minor side effects, those ones, it's not really necessary that we follow up on each and every report. So we go like a case by case. And I'm sure some of you have received our calls, our emails, even our letters where we are asking for additional information on some of the cases, especially the ones that are presented to the causality assessment committees. We have been reaching out, and we have been receiving some additional information. Others, they're not.
We just lost you. I don't know if you can still hear us.
Cases, and then there are those challenges in our communication systems, but it is something that is encouraged. Whenever we receive a report, we follow up on the patient, see how they are doing, and whether they have recovered from that side effect or not. And I've forgotten the third one.
The third one was on dissemination of results. Do you disseminate them manually, and what platforms are you using?
Okay, so it is, I can say it's in the pipeline. So we are working on our website. We have something that is in the pipeline where we want to be putting a line list of reports received, let's say in a quarter. So we just list them and put them there for the public to see what reports have been reported on which product, what side effects have been experienced for each and every product that has been reported on. So that is our line of thought. I hope this will work out very soon, but we have started working on that. And maybe by the end of this quarter, we might be able to put up something. But in the past, what mostly we've been doing is disseminating this information when we meet at these annual general meetings, and everywhere where there's a gathering, where there's a ZAMRA stand, we try to put up some posters, some brochures, and some information to give back to give the feedback on what assessments we have done. And some of the assessments might take longer because signal detection is not really a straightforward thing. Just like any other research, you need to get lucky sometimes. So sometimes you'll be lucky, you'll find something new, and then everyone will be willing to go in details and just assess that new signal and have it shared. But there is something that we are working on also, some reports, some posters we'll see, and we'll try to put them on the same website that we're working on, just to give that feedback. But yeah, during the meetings like this one also, we try to give, maybe in the terms of statistics, how many reports we have received, which provinces are doing well, and which provinces are not doing so well in terms of reporting, so that maybe some interventions or some partners can join in and maybe support sensitizations in such provinces. I hope I've responded to the question.
No, thank you so much for those responses, and also just thanking all the panel of experts that we had today and for the contribution at this stage. Mr. Kampamba, your last thoughts before we close.
Thank you so much, and great participation and insightful questions that were forwarded. Key things, of course, we've got routine pharmacovigilance, but we also have active pharmacovigilance that we are really encouraging. And remember, key where active pharmacovigilance is concerned, you report both the presence and absence of adverse effects. Then just to also encourage, pharmacovigilance is the reporter concerning the person who is reporting. Please know that it is not punitive. We are not looking for culprits to say, oh, if Chipata Level 1 hospital has reported, then they will be punished. Or this, but no. It's good for you and for me. And to wrap it up, your report, my report, counts to make our drugs safer for everyone to consume them. Thank you.
Thank you so much, Mr. Kampamba. Thank you, Network. I have seen a number of questions regarding the slides. You can find the slide deck on the iEcho site. So just go to iEcho, you'll be able to find the slides. They'll be uploaded by IT after this session. And then there's also a feedback form that has been shared by IT in the chat. Please, we appreciate your feedback. Otherwise, thank you so much. Enjoy the rest of the day. Until next week, Monday. This is your ECHO team. Thank you.
Thank you.
Thank you.